Next, let's talk about some of these adjuvant agents, such as antidepressants, anticonvulsants like gabapentin and pregabalin, which we'll primarily focus on, skeletal muscle relaxants, local anesthetics and local analgesics, and ketamine. With each of these, we're going to go ahead and give you the mechanism of action because you haven't learned it yet, and it can help sometimes inform how we use it. So let's start with antidepressants, tricyclic antidepressants. They work both on serotonin and norepinephrine. So they have a very similar mechanism of action as the serotonin norepinephrine reuptake inhibitors as well. So you can use lower doses for analgesia compared to antidepressant. The dosing is agent dependent. I will show you those here in a minute. There is a box warning associated with suicidal thinking and suicidal behaviors. We do want to avoid using this in patients that do have this risk. Some other notable side effects is it does have many anticholinergic side effects, including dry mouth, blurred vision, and constipation. Cardiovascularly speaking, it is associated with QTc prolongation and sudden cardiac death, especially at doses over 100 milligrams. Alongside that, you have tachycardia and orthostasis. Notably, there is a lot of dizziness associated with them, and it does decrease the seizure threshold. So you do want to avoid using it in patients with seizures, and that's why that is considered a contraindication. Likewise, there is contraindications for patients with cardiovascular disease, especially at high doses. Co-administration with MAOIs can cause serotonin syndrome, and also other agents that are serotonergic can cause serotonin syndrome as well. Cisazopride is associated with QT prolongation, and it is considered a contraindication that you should not use them together. In the recovery phase after an MI, tricyclic antidepressants are also contraindicated. Their place in therapy really is to be used in neuropathic pain, primarily as a first-line agent. Also can be used in migraine and fibromyalgia. One thing to keep in mind is that these do lower the seizure threshold. So in patients that have seizures, you do want to avoid them due to their seizure risk. There are many drug interactions, including anticholinesterase inhibitors, other serotonin agents due to the risk of serotonin syndrome, agents that prolong the QTc interval, and CNS depressants. I do not expect you to know all the drugs in all these categories, but one thing to keep in mind is that imipramine is not a preferred agent, and really what you'll see most frequently is amitriptyline or nortriptyline. Notably, amitriptyline is dosed at night and nortriptyline is dosed during the day because amitriptyline is much more sedating compared to nortriptyline. Next, you have serotonin norepinephrine reuptake inhibitors. These work, again, similarly, but however, they work on the reuptake of these, but overall will increase your serotonin and your norepinephrine. Side effects do still include dry mouth and erectile dysfunction. There is an increased risk for bleeding associated with any agent that does affect serotonin, and especially SNRIs. Hypertension has been associated with it, most likely related to norepinephrine. Its place in therapy has a benefit for patients that have other mental health diagnoses because you can use similar doses as that you use for depression, unlike in TCAs. It's used in fibromyalgia and low back pain, and as I already mentioned, duloxetine is mentioned in the lower back pain guidelines. It is considered first line for neuropathic pain. It is contraindicated if you've had an MAOI in the last 14 days and the use of other serotonergic agents. It has been associated with orthostatic hypotension and blood pressure increases, which this may seem backwards, but in many cases patients may have orthostatic hypotension or hypertension but not rarely at the same time. It is used in depression and pain, and as I mentioned before, it's nice that you use similar doses. Duloxetine is mentioned in the lower back pain guidelines. Your drug interactions are CNS depression, as you have the additive depression effects, anticoagulants because you have your increased risk of bleeding, and serotonin agents due to serotonin syndrome. As you notice, these are very similar to tricyclic antidepressants. Overall, SNRIs are slightly better tolerated, and you don't have that risk for cardiovascular, or not as much of a cardiovascular risk associated with these agents. Overall, the most commonly used agent is duloxetine. If you notice, venlafaxine has more QTc prolongation associated with it, and you need a higher dose sometimes for analgesic effect. So again, and minoprostine or Savella is only used in fibromyalgia. So duloxetine is the agent that you're going to see used most. You do not have to know agent-specific characteristics for this one. Now let's move to skeletal muscle relaxants, and there are a lot of them. And I did go a little bit more in depth about this one because I know you guys don't get this in pharmacology. Oh, sorry. We're not going skeletal muscle relaxants. We have to do anticonvulsants first. So I'll start with anticonvulsants. I apologize. So our primary anticonvulsants that we're going to talk about are gabapentin and pregabalin. Notably, they are controlled 5 substances, so you will be able to see them on the Virginia PMP. They are structurally related to GABA, and it does modulate excitatory neurotransmission, but overall it just has very GABA-specific effects and causes overall CNS depression. You do have these two agents, gabapentin and pregabalin, and overall they are very similar to one another. The side effects include ataxia, dizziness, drowsiness, fatigue, and there is a potential for withdrawal. Now, there is euphoria associated with gabapentin, and that's one of the reasons why it has the C4 specifications, or C5 specifications, because there is some risk for dependence. In some cases where a patient has risk factors for dependence, you may want to avoid using agents. That's why it has the contraindication for substance abuse. These agents are both exclusively excreted renally, so for that reason, in patients with renal impairment, it is important to dose adjust and try to avoid therapy whenever patients have very low renal function, such as less than 30. Pregabalin is associated with angioedema, and gabapentin at certain doses has been associated with sudden cardiac death. Though there are no specific recommendations regarding treatment, other than for pregabalin and the angioedema, if you are somebody who has had angioedema associated with ACE inhibitors or other agents, you might want to avoid it. Both have been associated with a tumorigenic potential, as patients have developed tumors while on therapy. It is something that you would want to monitor for. These are considered first-line treatment for neuropathic pain. There is some indication in post-operative pain or perioperative pain. Using gabapentin preoperatively may decrease opioid need. Post-therapeutic neuralgia, they are mentioned in those guidelines as well. The major drug interactions really are revolving around other CNS depressants and causing an overall CNS depression effect. Now let's talk about skeletal muscle relaxants. Skeletal muscle relaxants can be divided into two different groups, antispasticity and antispasmodic. Spasticity means that you have an increased muscle tone or stiffness, resulting in undesirable and uncontrolled movements. Versus antispasmodic and spasmodic agents really are for decreasing muscle spasms. Antispastic agents work on spinal cord and skeletal muscles to decrease hypertonicity and involuntary spasms. A lot of times this is associated with MS. Baclofen and dantrolene are the two antispasticity agents. Baclofen is primarily used because dantrolene is associated with serious side effects, including liver dysfunction. Your antispasmodics are used more for lower back pain and other types of muscle spasms. And when we talk about symptom-driven therapy, really when patients start talking about having spasms, this is what agents will use. Now, there are some agents that have both properties, including benzodiazepines, which we are going to try to avoid in most patients due to the risk and the potential for abuse, and tizanidine. When we look at the different therapies, again, this is your antispasticity, and these are your antispasmodics. This is both. These are all your antispasmodics. You'll see that the mechanism of actions are very different from one another. But sometimes the mechanism of action helps us talk about what the side effects will be. So for example, gabapentin works on the spinal cord, baclofen works on the spinal cord on GABA. So usually you'll see an overall CNS depression associated with it. Methylcarbamol causes overall CNS depression as well. Notably, cyclobenzaprine is structurally related to TCAs, and for that reason they have many anticholinergic side effects associated with them. And tizanidine is a central-acting alpha-2 agonist. This is very similar to the blood pressure drug clonidine, so it will have similar side effects to it. It is good to note that cardisoprol is a controlled for substance. Baclofen overall's place in therapy, and all these agents' place in therapy really revolves around muscle spasms and musculoskeletal conditions. The side effects to note for each agent is highlighted here. One thing to remember is baclofen does have a withdrawal syndrome, so you do want to make sure you titrate off therapy. Methylcarbamol is associated with seizures and can decrease your seizure threshold. It and baclofen are contraindication in patients with seizure disorders, as you can see here. Cardisoprol overall is well tolerated, but it has that risk for substance abuse and dependence, and for that reason it is a controlled for substance. As I mentioned before, cyclobenzaprine is very similar to tricyclic antidepressants in its structure and mechanism of action, and for that reason you do see more dry mouth associated with it and other anticholinergic side effects. Scalaxin, although usually well tolerated as far as it has much less CNS side effects compared to some of the other agents, it is associated with some really bad side effects of anemia and hemolytic anemia and leukemia. So for that reason, it's used much less frequently. Also, it's not been shown to be overly effective. And then finally, you have tizanidine. As I mentioned before, it's very similar to the the hypertension agent clonidine. So you will see that it causes hypotension and bradycardia. But overall, these agents do have very similar side effects in the fact that most of them do cause general CNS depression. And you'll see here that their drug-drug interactions reflect this, with all these having drug interactions associated with CNS depressants. Cyclobenzaprine and tizanidine have additional drug interactions to note, with cyclobenzaprine having additive effects with anticholinergics, and tizanidine having CYP2A218 interactions. I've actually seen a patient get really, really hypotensive and bradycardic and almost die in the ICU due to this drug interaction between tizanidine and ciprofloxacin. Cyclobenzaprine, it's also notable that it does have the risk of heart failure and arrhythmia and shouldn't be used in patients that have underlying conditions related to them. And it is serotonergic, so it shouldn't be used in patients that have or are on a MAOI inhibitor. Next, we can move to local anesthetics / local analgesics. So let's start with lidocaine. Lidocaine can be used in many different forms. Now, the general consensus is the IV form is used not as much in pain management other than for small doses intraoperatively, but more for as an antiarrhythmic. And you will see those antiarrhythmic side effects. However, when we're using the patches and local, using it for local as far as like intradermally, you don't see those side effects as much. They do work on sodium channels to prolong nerve depolarization. You'll see that there are several contraindications and precautions, but a lot of them really deal with the local side effects, including having a traumatic mucosa or bacterial infection or other kind of lesions around the area where you're trying to use these. They are available in several different forms, including a patch. Patches are second line in acute pain related to neuropathic pain, and that's really their place in therapy. Side effects are listed here. You can note that most of these side effects are quite rare, and most patients will just have local dermatological side effects. The patch is relatively well tolerated, and it has a very low drug interaction and side effect profile compared to lidocaine injected. Next, we have the local analgesic capsaicin. You'll notice that I have a pepper on here because it is a derivative of peppers. And it comes in several different formulations. Qutenza, the patch, is mentioned second line for neuropathic pain, but it is interesting that you can only repeat it every 3 months and you can only use it once in that area. These patches are OTC patches that can be used as long as you don't use them for more than 5 days. And then you have creams that can be applied to the area 3 to 4 times a day and used very frequently. Most side effects really revolve around burning and pruritus. If you think about it, you're using pepper on your skin, and if you get it in an eye or mucosal membrane, it's going to hurt. It is a second-line agent in neuropathic pain, and this is mostly the patch, the 8% patch. And it can be used as an adjunctive in nociceptive pain, especially in patients that are using non-opioid topical therapies. You don't want to really use it on areas of broken skin, just like lidocaine, and it can cause serious burns, and you want to avoid eye contact with eyes, mouth, or genitals. Again, you're using peppers pretty much. It has been associated with some reduction in sensory function as well, and you should try to avoid it in areas where the patient has decreased sensory function, such as in patients with diabetic foot infections. If you do use the agent, you do want to make sure that you use close monitoring. It is important to remember that there are the 2 different doses of the patches and they both get dosed differently. It can be used on hands and knees. Sorry, that says needs. For the cream, and it does come in OTC formulations. Finally, we can talk about ketamine. Ketamine's mechanism of action, it is an NMDA receptor antagonist. You'll see the dosing here. It's not that important for you to know. It is used as a continuous infusion and a bolus. You'll see that the continuous infusion is per hour here. The biggest side effect to keep in mind, so ketamine is a street drug, and it's a psychomimetic drug. Thus, it can make you feel a little crazy. So for that reason, it can cause confusion, delirium, irrational behavior, and vivid imagery. It shouldn't be used in patients that have schizophrenia or acute alcohol intoxication for that reason. So it's associated with increased blood pressure and pulse, along with increase in hypertonia, and it can cause AST and ALT elevations. It does have CYP3A4 interactions. It's only really used in the hospital for acute pain, though it's starting to be used a little bit in chronic pain in outpatient clinics and in selected outpatient clinics, but it does require a lot of monitoring. It does have that psychomimetic properties, so for that reason you do want to avoid it in schizophrenia, as I mentioned before. Most of its drug-drug interactions really revolve around CNS depressants, causing an additive effect, and CYP3A4 interactions. In our next section, we'll talk about opioids.